What's up, guys? Today we're going to discuss types of shock on USMLE. This is extremely high yield. We're going to focus on 10 questions with relevant explanations. So let's jump right into it. So we have a 72-year-old male with fever, dysuria, and confusion. His blood pressure is 82/46, heart rate is 128. He has warm extremities, bounding pulses, and a lactate of 5.1. What are the hemodynamics? So take a moment and pause here and try to answer this on your own, but we're going to jump into this question. The key to this question is to understand that this patient has a fever, dysuria, confusion, which are all signs of some process such as sepsis, right? And that's confirmed because the blood pressure is 82/46 and there's compensation of the heart rate of 128. And also elevated lactate means low perfusion. So this is all pointing towards a septic picture, okay? And when you have septic shock, what ends up happening with your hemodynamics is initially your cardiac output is going to be high. Initially, your cardiac output will be high initially, and your systemic vascular resistance will be low. And this reason behind this is in sepsis, it's an inflammatory response, and that kind of, in your capillaries and other vessels, it kind of leaks out volume, right? And what ends up happening is that your vessels become also dilated. So that means that you have dilated vessels, which means that you have a lower systemic vascular resistance. And because of this, initially your heart rate increases and your cardiac output increases because your body is trying to compensate for that. So if you know this and you know that you have like leaky vessels, right, your preload is going to be low because you're going to have decreased venous return to the heart because all the volume is leaving your vessels, right? So you have a lower preload, and for all intensive purposes on USMLE, whenever you're given a PCWP, which is a pulmonary capillary wedge pressure, that's exactly the same as preload, okay? It should be synonymous with preload. And the reason behind this is because of when you're trying to measure using a Swan-Ganz catheter the pressures of the heart, you can't really measure the pressure of the directly. You can't measure the pressure of the left ventricle at the end of diastole. So you basically insert it to the pulmonary capillary. And at a certain point, when you have diastole, the left atrium pressure and the left ventricle pressure are equal. That's what you're measuring. So that's like a kind of rough estimate of preload. And so they just named this PCWP, but you should definitely know it's the same as preload. So you'll have a decreased preload, decreased systemic vascular resistance, and an increased cardiac output in septic shock, okay? And that schematic would be answer choice C. Okay, for the next question, we have a 66-year-old male who develops hypotension after a STEMI. He has crackles, JVD, and cool extremities. What's the hemodynamics? So take a moment and pause here. We're going to jump into the question. So hypotension after STEMI, and there's crackles, JVD, and cool extremities. So whenever you have a STEMI, you have essentially an occluded coronary artery, right? And if you have an occluded coronary artery, what ends up happening is you have myocardial wall damage, right? So if I just draw a poorly drawn heart here, and you have your coronary arteries here supplying the muscle of the heart, and then there's an occlusion here, this wall is going to be damaged, right? And if so, the wall of the heart is damaged, the heart cannot pump correctly, right? So the pump is damaged, right? So when the heart pump is damaged, that is cardiogenic shock, all right? So since the heart is damaged, you will have a lower cardiac output, right? Because the heart is not pumping right, so the cardiac output will be lower. And once you know that the cardiac output is lower, your body tries to compensate for this. So what ends up happening is your body tries to increase, its blood pressure, and so the vessels will become constricted. And when the vessels become constricted, that means that your systemic vascular resistance will be higher. Okay? And now we're going on to PCW, P, right, which is preload. So since your heart cannot pump well, right, the fluid stays, the volume stays in the heart longer, right? So that means that you have an increased preload. And what do we say about preload? Preload is the same as PCWP. So that will mean you have an increased PCWP. Okay, so the schematic here would be a choice A, right? And another point I want to mention that was on the previous segment is once you have cardiac failure, you do have JVD and pulmonary congestion. And the reason is because, all the fluid gets backed up. So if you draw your heart, you have your right atrium here, your right ventricle here, your left atrium here, your left ventricle here, and you have your SVC dumping blood into the right atrium. Right ventricle, you have the pulmonary artery. Left atrium, you have the pulmonary veins coming in, and then the left ventricle, you have the aorta. So once you have this pump failure, all the fluid gets backed up, right? So the fluid gets backed up into the lungs, right? The fluid gets backed up into the SVC because the heart's not pumping well. And if you go all the way up, you also have JVD. So that's why you have increased JVD with any sort of heart failure or cardiogenic shock. All right, so you have a post-op patient with sudden dyspnea, hypotension, JVD, and clear lungs. What's the cause? So pause here and try to figure it out. But a post-op patient, right? So post-op patient with sudden dyspnea, you usually have to equate that with pulmonary embolism. And the reason why is because when you have a post-op patient, they're not mobile, you're not getting blood flow, you have blood stasis that has, that gives you an increased chance for developing a blood clot, which develops into a pulmonary embolism, embolizes into the lungs. And so if you know this relationship, you can easily just, get the answer choice C. But let's say you didn't know this relationship, how would you approach this question? You'll look at the answer choices and you'll see that the left ventricular failure here wouldn't make sense because we know that left ventricular failure would be most likely due to myocardial wall damage. And if you have myocardial wall damage, that will cause fluid to back up into the lungs. So you wouldn't have clear lungs, you would have crackles on your lungs, and it just wouldn't make sense. So choice A is out of the question. Choice A is out of the question. Choice B, vasodilation, that would be more consistent with sepsis, right? But there's no fever here to suggest that. So B is out. Obviously C is the right answer. But let's say you're considering D, blood loss. So yeah, blood loss would cause hypotension, but you wouldn't have JVD with hypovolemic shock, which is choice D, right? You wouldn't have JVD with hypovolemic shock. You would have hypotension, but you just wouldn't have JVD, and you wouldn't have dyspnea necessarily with hypovolemic shock. So D is out of the question. So choice C is the right answer, but let's talk about it a little bit more detail. So a PE, that's a type of obstructive shock. And what that means is you have some sort of obstruction, right? In this case, the embolism that's causing the shock, right? So if you draw your heart again, you have your right atrium here, your right ventricle here, your left atrium here, left ventricle here. You have your SVC dumping blood into the right atrium. You have your pulmonary artery getting the blood out to the lung circuit, right? Then you have your pulmonary veins bringing the blood back into the left atrium, and then you have your aorta coming out of the left ventricle, right? So if you have a blood clot over here, right, what ends up happening is the blood cannot pump effectively out of the right ventricle, which leads to blood going backwards, right, up to the superior vena cava and the JVD, right? So in that case, you will have hypotension because you're not pumping blood forward, and you'll have JVD, and that's the reason why you'll have decreased preload, because you have an obstruction here along this circuit, which means that the blood never comes, or the blood has a difficulty coming back to the left atrium, which will cause a decreased preload. All right, and that's why choice C is the right answer. So in this question, you have a cervical spinal cord infarction. The blood pressure is 76/42, heart rate is 40, and the patient has warm skin. What's the feature distinguishing neurogenic shock? This is a very simple question, okay? Neurogenic shock is pretty much, for all intents and purposes, the only type of shock where you will have a decreased heart rate, okay? Almost in every other type of shock, you will have an increased heart rate, right? Your body's trying to compensate for the low blood pressure. But in neurogenic shock, you'll have a decreased heart rate. And the reason why is because your sympathetics are kicked. They don't work. They just don't work in neurogenic shock. So that means that your heart rate can't go up higher. I mean, your body would love to get your heart rate higher, but you can't because you have this spinal cord injury, right? So that's why choice C is the right answer. Don't think about this too much. If you see a low blood pressure with a low heart rate in the setting of a injury, like a traumatic spinal cord injury or infarction, it's neurogenic shock. Don't think about it too much. That's the answer. It's very simple. Okay, so which shock has elevated PCWP, pulmonary capillary wedge pressure? So take a moment and try to answer this on your own, but we'll just go through every answer choice here. So septic shock, is that the right answer? No, it's not. The reason why it's not is because, remember, we were discussing earlier, when you have septic shock, you have your blood vessels, and your blood vessels become dilated and leaky, right? And the leakiness will cause the fluid to get out of the blood vessels, which means you'll have a decreased preload in septic shock. Right, so remember we said that PCWP is preload, and we'll have a decreased preload in septic shock, so that cannot be the right answer. All right, so that's not the right answer. Cardiogenic shock, right, that is the answer. You will have an elevated PCWP in cardiogenic shock, but let's get back to that later. Let's go to hypovolemic shock. In hypovolemic shock, you'll have a decreased PCWP, right? When you have hypovolemic shock, the volume is not in your blood vessels because you're losing blood from somewhere, right? From either trauma or anywhere else. So it's getting extravasated. So it's not in the vessels. So obviously it's not going to show back up into the venous return circuit. And so it can't be hypovolemic. So it can't be hypovolemic either. And then lastly, anaphylactic. It can't be anaphylactic either because, kind of similar principle to like a sepsis picture, it's a type of distributive shock. You're decreasing the amount of volume in your vessels, so you're not going to have increased preload, right? So it cannot be choice D either. It can be choice D. The right answer here is cardiogenic shock. It's one of the only, well, it's one of the types of shocks that has increased PCWP, and the reason why we discussed earlier is when you have, myocardial wall damage. So let's try your heart again. So we have the right atrium, right ventricle, left atrium, left ventricle. Let's say your aorta comes out from here. If you have wall damage, right, your heart cannot pump effectively, right? So your heart cannot pump effectively, meaning what ends up happening is that all the blood gets pooled over here. If all the blood gets pooled over here, you have an increased preload, essentially, in cardiogenic shock, okay? And that's why it's the answer. All right, so this is an interesting question. Septic shock has, an SVO2 of 82%. Why is this the case? So what is SVO2? So SVO2 is essentially mixed venous oxygen saturation. Now, what does that mean? All that means is that it's a measure of the percent of oxygen bound to hemoglobin in blood returning to the right side of the heart. Okay, so let's assume that you have, your blood vessels here, and they have some O2, right? And then they're, going to tissues over here, right? So these are the tissues, and then this, deoxygenated blood, right? So I'll just call it like deoxygenated blood is going back to the right side of the heart, right? The right side of the heart. So what SVO2 is the measure of oxygen bound to hemoglobin when it returns to the right side of the heart, right? So in this case, the tissues, right, in sepsis, the tissues are utilizing oxygen less. Why is that the case? Remember, in sepsis, you have a increased cardiac output initially, right? In sepsis. So what does that mean? That means, you have an increased heart rate, and your heart is pumping so fast, and blood doesn't have enough time to spend in the tissues, right? So if you're not spending enough time in the tissues, then you have an increased oxygen saturation on this side, right? Because you're not spending enough time in the tissues. So that's why your SVO2 is going to be higher in a sepsis picture. Because for the reason your oxygen doesn't have enough time to get unloaded in the tissues because your heart is pumping so fast. And that's why B is the right answer. All right, so you have a trauma patient, heart rate is 138, blood pressure is 78/42. The patient has flat neck veins and cool extremities. What's the first physiologic response? So what type of shock this is kind of relevant, but you can probably answer this question without that. So this patient has been probably, stabbed or shot or something, right? A trauma patient that's hypotensive, flat neck veins. This seems like a hypovolemic shock, right? They're losing blood from somewhere. They either got stabbed or shot or some kind of blunt injury. Something happened, right? And they're losing blood. It's coming out of their vessels. It's getting, anywhere but the heart. It's going anywhere but the heart, this blood that they're losing. And so what's the first physiologic response? Well, if you look at all of this, the only one that makes sense is choice A. Your body is losing a lot of blood, so naturally it wants to increase its heart rate and increase the systemic vascular resistance, and so you have an increase in sympathetic nerve stimulation. Vagal activation wouldn't make sense. That's like directly the opposite, right? It doesn't make sense. Vasodilation, that would make your blood pressure worse. You know, why would that make sense? You have decreased resistance. It wouldn't make sense. And ANP, that just doesn't make any sense at all. You know, that would firstly take a long time to happen, so it doesn't make any sense. Um, and A is the only right answer here. All right, the next question is you have hypotension, JVD, muffled heart sounds after a stab wound. What's the treatment? Before you answer this question, you have to know what it's asking, right? So you have a patient who's hypotensive with JVD, could be a lot of things. As soon as you put in muffled heart sounds, this becomes Beck's triad, okay? Beck's triad is literally hypotension, JVD, and muffled heart sounds. And that's after a stab wound. So what's the treatment? The treatment is pericardiocentesis. The reason why is if you draw your heart again, let's draw our heart again. So you have the right atrium, right ventricle, left atrium, left ventricle, and you have this heart. And obviously the heart sits in a sac, right? And so if you have, let's say, a stab wound and you have a laceration here, blood will fill this sac, right? And once blood fills this sac, the pressure of this sac does not allow the right ventricle to fill in diastole, right? You can't fill because there will be an equalization of pressures. And the only way for the right ventricle to fill, you know, relieving the obstruction, is by draining this fluid around the heart sac, and that's called a pericardiocentesis, all right? So that's the answer, choice B. Furosemide, that would be if you're having cardiogenic shock and you need to get fluid off the patient. Dobutamine, again, it's more of like a cardiogenic shock. Nitro is more of a cardiogenic kind of shock etiology where you want to decrease preload. So all these other things are pointing to cardiogenic shock, and they're not the right answer. In this case, you have an obstructive type of shock because you have Beck's triad. And you need to relieve the pressure of the pericardial sac by taking fluid out of there via pericardiocentesis. So you have a persistently septic hypotensive patient, you know, even after 30 ml of kg, which is the, you know, recommended fluid resuscitation for septic shock. What's the next step? Obviously, you're going to start pressors, especially when you're having septic shock that's not responsive to fluids. But what's the first choice pressor? That will be choice C. Answer choice C, norepinephrine. That's the first line pressor, pretty much in any type of shock, okay? If you're stuck on a question and you're not sure, but you know that a patient is in shock, you're not sure what pressor to give, don't think about it too hard. The first pressor, just choose norepinephrine. You'll get it right 95% of the time. All right, so USMLE, they love their arrow type questions. You will get a bunch of questions on you know, your USMLEs regarding arrows. And so you have a low cardiac output, you have an elevated systemic vascular resistance, you have a low pulmonary capillary wedge pressure, and you have a low mixed venous oxygen saturation. What's the type of shock? As we discussed, we know that right away that in septic shock that you'll have a high SVO2. So it's not choice A right off the bat. And also, initially in sepsis, you would have a high cardiac output. So it's not septic shock, right? Now let's look at cardiogenic shock. Remember we discussed in cardiogenic shock, you will have a increased preload, right? Because your heart isn't pumping well, so the fluid gets pooling in the left ventricle because you can't really pump it out well, so you have an increased preload. So in this case, it's giving us a decreased preload, so it's not choice B. Now let's go to a hypovolemic type of shock. So in hypovolemic shock, you will have a decreased cardiac output because you do have decreased preload because blood is not coming back to the heart, right? So choice C looks very, very good right now. It might be the right answer. But why is this not neurogenic shock? In neurogenic shock, remember, we have decreased or diminished sympathetic activation. When you have diminished sympathetic activation, you're not going to be able to vasoconstrict your vessels, leading to increased systemic vascular resistance. So in this case, it's not neurogenic shock, right? Because in neurogenic shock, you will have a decreased SVR because you don't have sympathetics, right? In cardiogenic shock, let's go to cardiogenic shock, you'll have an increased preload, right? And in septic shock, you will have a increased SVO2. So the only one that makes sense is choice C. Quick summary table so that you will never get any of these wrong. If you remember these arrows, you will be golden on test day. However, I really want you to understand the principles behind all of this. So you don't have to remember anything on test day. And we discussed the principles for everything extensively, essentially.